Every single drop of blood flowing through your veins right now is carrying a microscopic, highly specific biological barcode. And in the world of medicine, reading that barcode incorrectly isn't just a minor slip-up, it is instantly, terrifyingly fatal. So let's dive right in. What actually goes down if you receive the wrong blood type during a transfusion? Well, your body doesn't just passively reject it. It mounts this massive, life-threatening immune response. It treats the new blood like a lethal invader, triggering a cellular war that can literally shut down your organs in minutes. Understanding how to read these invisible codes is the absolute fundamental difference between a life-saving intervention and a deadly crisis. Section 1. The Blood Group Code. To prevent that catastrophic immune response, medicine relies on two incredibly significant classification systems. This is the foundation of it all.
Okay, to really understand this, we've got to look at two main players here, antigens and antibodies. Think of antigens as the genetic ID tags, or the barcodes sitting right on the surface of your red blood cells. You inherit these from your parents, and they stay exactly the same for your entire life. Now, floating around in the plasma surrounding those cells are your antibodies. Think of them as aggressive security guards or bouncers. Their whole job is to scan the blood, and if they spot an antigen ID tag they don't recognize, they attack it mercilessly.
Before we cracked this barcode, blood transfusions were essentially a deadly game of biological roulette. But that changed back in 1901 when a brilliant scientist named Carl Landsteiner discovered the ABO system. This completely revolutionized transfusion medicine, and mortality rates just plummeted. Decades later, in 1940, Landsteiner and Alexander S. Wiener were actually experimenting with Rhesus monkeys, which, by the way, is a wild but fascinating origin story, and they discovered the second vital piece of the puzzle, the Rh factor. Together, these discoveries turned a deadly game of roulette into a calculated science.
Moving to Section 2, the ABO system. Let's look at how this first major system is determined by genetics, specifically inherited directly from your parents through chromosome 9. Here is your ultimate ABO cheat sheet. The whole system classifies blood based entirely on whether you have the A antigen, the B antigen, both, or neither. Look at Group A, for example. They have the A ID tag, so their bouncers are anti-B. Group B has the B tag, so their bouncers are anti-A. It's a simple biological logic, but it dictates exactly who can safely donate to whom without triggering a war in the bloodstream.
Now what's really fascinating here is Group AB. Notice their plasma antibodies? They have 0. Because their red blood cells carry both the A and the B ID tags, their immune system doesn't produce any anti-A or anti-B bouncers. Since they have absolutely no security guards to attack incoming blood, Group AB individuals are the universal recipients. They can safely receive A, B, AB, or O blood. No problem.
And on the exact opposite end of the spectrum, we have Group O. These red blood cells are completely blank. They have 0 A or B antigens. Because they lack those ID tags, you can put Group O blood into anyone, and the recipient security guards won't notice a thing. This makes Group O, especially O negative, the universal donor. In severe, chaotic emergency situations where there is just no time to test a patient's blood type, Group O is the ultimate life-saving backup. Section 3. The Rules of Compatibility. Because what happens on the hospital floor when these rules are broken is a truly terrifying reality. If a patient gets incompatible blood, the donor cell's antigens clash hard with the recipient's antibodies. This causes hemolysis. The red blood cells are quite literally destroyed. As they burst open, free hemoglobin just floods the circulation. Suddenly, the patient spikes a fever, experiences severe chills, and starts complaining of intense chest and back pain. And it doesn't stop there. Their blood pressure plummets. They can go into shock, and that free hemoglobin will aggressively attack the kidneys, causing acute kidney injury and dark urine. Left untreated, this cascade leads to death.
So, the crucial point is how medical professionals respond to this. We're talking rapid-fire, high-stakes emergency actions. Step 1. Stop the transfusion immediately. The very second these signs appear, you halt the invasion. Step 2. Keep the IV line open, but only with normal saline to flush the system. Then you immediately notify the physician and the blood bank, send blood samples off for investigation, and closely monitor vital signs and urine output. Fast action here is quite literally the only way to save the patient's life. Section 4. The Rhesus or Rh factor. Let's add the second major layer to our biological barcode, specifically looking at the D antigen.
The Rh system is all about one specific tag, the D antigen. If you have it, you're Rh positive. If you don't, you're Rh negative. Globally, about 85% of people carry this D antigen and are Rh positive. That means the remaining 15% who lack it face some very unique and potentially very severe medical risks.
Here's where things get tricky for that 15%. If you're Rh negative, you don't naturally have anti-D bouncers. But if you were ever exposed to Rh positive blood, say through a transfusion, a trauma, or during pregnancy and miscarriage, your immune system wakes up. It recognizes those Rh positive cells as a foreign threat and permanently builds anti-D antibodies. This is called Rh sensitization. The first exposure sensitizes you. Any exposure after that, it triggers a rapid, massive destruction of the Rh positive cells. Section 5. Incompatibility in pregnancy. This brings us to a field where these invisible immune rules create the highest possible drama: maternal fetal medicine. When an Rh negative mother is carrying an Rh positive baby, it sets the stage for a really dangerous clash. If the mother was previously sensitized, her immune system views her developing baby's blood as a foreign invader. Her anti-D antibodies will actually cross the placenta and aggressively attack and destroy the fetus's red blood cells. We call this Hemolytic Disease of the newborn, or HDN. The consequences of HDN, if it's allowed to just run its course, are absolutely devastating. Before birth, the baby suffers from severe anemia, which leads to enlarged organs and a life-threatening swelling condition called hydrops fetalis. And after birth, the massive breakdown of red blood cells causes extreme jaundice and hyperbilirubinemia. If those bilirubin levels get too high, they can cross right into the brain, causing kernicterus, which is permanent brain damage. It can lead to heart failure, stillbirth, or neonatal death. But modern medicine has a truly incredible solution for this. We use a preventative miracle called anti-D immunoglobulin. It's essentially an injection that acts as a stealth team. It goes right into the mother's bloodstream and destroys any stray fetal Rh positive cells before her immune system even has a chance to notice them. By doing this, it completely prevents her from forming those dangerous antibodies in the first place. This is given around 28 weeks of pregnancy and again within 72 hours after delivery, plus after any trauma or miscarriage. It's a game changer.
Now, it's super important to draw a crystal clear distinction between Rh incompatibility and ABO incompatibility in pregnancy. ABO incompatibility happens, for example, if a Group O mother carries a Group A or B baby. Her antibodies can cross the placenta, but the results are vastly different. ABO incompatibility usually affects the first pregnancy and is much, much milder, often just resulting in jaundice that responds really well to simple phototherapy. Rh incompatibility, on the other hand, requires prior sensitization, gets worse with later pregnancies, causes severe hemolysis, and absolutely requires that anti-D medical intervention.
Because of all these risks, vigilant nursing management is critical. Medical teams are constantly assessing maternal and fetal blood groups and Rh status. For newborns, they're monitoring hydration, supporting breastfeeding, tracking bilirubin levels to watch for worsening jaundice, and administering phototherapy or preparing for exchange transfusions if needed. The great news here is that by ensuring the proper administration of that anti-D immunoglobulin and deeply educating parents, modern healthcare has this incredibly well managed, drastically reducing neonatal risks. Think about it. By discovering and mapping the ABO and Rhesus systems, modern medicine literally turned a fatal genetic clash into a highly manageable condition, saving countless lives in emergency rooms and maternity wards around the world. But it really leaves you wondering, if something as invisible as a tiny antigen on a single red blood cell holds the power of life and death, what other invisible biological codes are we carrying around in our DNA right now, just waiting to be decoded?